Hi, welcome to QD Clinic. I'm Jack Cush. QD Clinic is brought to you by Room Now Live, where it's all about getting inspired, interacting, and the best of education. Our case is periorbital mass. Doesn't this sound familiar to a recent case, like maybe yesterday? Except this one is not in a teenager. This one is a 60-year-old black female who presents with an orbital mass. I mean, it's big, it's one-sided. The whole eye is shut. You can kind of pry open the eyelids, and the eye and the orbit, the eyeball will move right and left and focus, and vision is not impaired. There's not proptosis, but the whole eyelid is gigantically swollen, is uncomfortable, is associated with some fever, is associated with double vision that's going on for, she says, like 6-7 months, and it's actually getting worse. Negative labs, chest x-ray was normal, an MRI was done and showed a significant amount of unilateral lacrimal gland enlargement without any distortion of normal architecture. No other infiltrative masses or tumors were seen. She underwent a biopsy. The biopsy came back with non-necrotizing granuloma, a lot of inflammation, multinucleated giant cells present, felt to be compatible with, you guessed it, sarcoidosis. So this is a very, I've actually seen this is maybe the fourth case I've seen in my career. They they all presented kind of the same way. They all were a little bit difficult to diagnose. They made their rounds between ophthalmology, ENT, sometimes a hospital admission and whatnot. No other systemic involvement. This was localized involvement. We sent this patient on just to be reevaluated. She had already been evaluated by oncologists and cleared an infectious disease as not having infection nor having any kind of malignancy. She was seen by pulmonary just to make sure that there was nothing else going on. A CT of the chest did not show any hyaluroadenopathy or other involvement within the lung. So this is isolated involvement. She was put on prednisone. Very little response. Of course, since this is sarcoidosis, we really stepped up to the plate and gave her methotrexate. A little bit better response. What are you going to do next? Well, there might be other choices, and we ended up putting her on rituximab. Why? Literature search at the time suggested it. There was obviously a lot of discussion going on at the onset that this could be an IgG4 related disease, and we know that they respond very well. There's also good evidence that refractory sarcoid can also respond well to sarcoid. We could have used a JAK inhibitor, an IL-6 inhibitor. Anyway, she did fabulous on rituximab. She received 4 courses, each course being 2 infusions of rituximab. We gave them every 6 months apart, and she was really in remission and doing great. Now, the question is, we are 4.5 years down the line. The swelling is gone. The eye function is preserved and normal. And she wants to go off methotrexate. Again, she has not received rituximab in 3 years. So what do? Well, we cut her methotrexate in half. She was only taking, at this recent visit, 7.5. And we were going to talk about the odds of recurrence, which I would have put at about 20% if she had fully gone off. But then I did an exam. And the exam showed what? She had normal pupillary function, normal vision. She had near normal extraocular movements, except her involved eye did not, let's say that's the right eye, did not track equally well with the left eye. And especially was apparent on when she would go to extreme lateral movement, that she would have some weakness there. She would lag at the end and not go fully over. But when she went medially, she would go fully over and she would track better. So maybe some lateral rectus weakness. And then she still had a little bit of puffiness on the medial side of that eye. So I said to her, listen, let's go another step. Let's go ahead and get an MR of the orbit to see if there's any mass or inflammatory activity, especially since we're now down to a lower dose of methotrexate. She was okay with that, because now if we find that she has residual inflammatory tissue, we're certainly not going to be rushing off and stopping her methotrexate. We probably would get her reevaluated by ophthalmology. we probably would do another total reevaluation, making sure that this still is just sarcoidosis and not infection, malignancy, IgG4, etc. Again, I think this is a very successful case of sarcoidosis that's been managed first with prednisone, methotrexate, and then rituximab. I think the learning point here is that sarcoidosis is more than just lung disease and arthritis, and the arthritis likes to be oligoarticular ankles and lower extremities more so than upper extremities. Extrapulmonary involvement is not uncommon. I like to remember and teach that the other name for sarcoidosis is called uveo-parotid fever, meaning they can get uveitis, an eye involvement, in this case lacrimal involvement. They can get parotitis and also lacrimal involvement, and they can get fever. But there's obviously there's other skin manifestations like enodosum and papular lesions and lupus pernio, where they get lesions over the face, nose, and like malar areas. They can get Sjogren's-like manifestations from their parotid involvement. Myositis and myopathy has been described. Liver, nerve, and renal involvements have also been described. This patient just isolated lacrimal gland, all sarcoidosis. And yes, being managed by a rheumatologist. Are we not the greatest physicians in all the world? The greatest physicians go to Room Now Live. See you there.